One of the easiest way to lose points on the USMLE exam is confusing the different types of shock. In this video, I am going to teach you exactly what you need to know to differentiate cardiogenic shock from other forms of shock. Keep watching. At the end of this session, you'll be able to define cardiogenic shock, differentiate it from other forms of shock, and identify key exam clues in the USMLE exam. As you can see, I made a slide for this session. So we are going to start with your question. A 65-year-old woman is brought to the hospital due to sudden onset chest heaviness and shortness of breath that began an hour ago. Her medical history is significant for type 2 DM, obesity, and hypertension. Temperature is 36.7 degrees Celsius. Blood pressure is 80-50 millimeter mercury. Pulse is 110 beats per minute, and respirations are 20 cycles per minute. Extremities are cold and clammy. There are bilateral lung crackles, elevated jugular venous pressure, diaphoresis is present. ECG shows ST segment elevation in the lateral leads. Which type of shock is most likely in this patient? Option A, septic shock. B, hypovolemic shock. C, cardiogenic shock. D, neurogenic shock. And E, obstructive shock. The right answer is cardiogenic shock. The patient has an acute myocardial infarction. If you listen to the question properly, you notice that she has sudden heaviness in her chest. Also, there is ST segment elevation in the lateral lead. This points to acute myocardial infarction. Then she has hypotension, a BP of 80/50 millimeter mercury. There is elevated jugular venous pressure. This is a pointer to heart failure. And also, there are bilateral lung crackles, which indicates that there is pulmonary edema. So these features are suggestive of a pump failure, which is the hallmark of cardiogenic shock. So what is cardiogenic shock? Cardiogenic shock occurs when the heart is unable to pump enough blood to meet the metabolic demand of the body. So it can be caused by acute myocardial infarction, like in this clinical scenario. It can be caused by papillary muscle rupture, which can also occur in myocardial infarction. It can be caused by severe arrhythmias. So in the pathophysiology of cardiogenic shock, what happens is that the heart fails. When the heart fails, there is decrease in cardiac output, leading to decrease in blood pressure. When there is decrease in blood pressure, the organs are poorly perfused, poor organ perfusion. This will now make the kidney to trigger RAS. RAS is renin-angiotensin aldosterone system. This system helps the body to absorb more fluid because there is poor organ perfusion. But when this fluid is absorbed, more fluid is absorbed in the body, it is detrimental because it will raise the systemic vascular resistance and the fluid will back up in the lungs. And because the heart has failed and it's not able to pump out this blood to the body, fluid keeps backing up in the lungs, leading to pulmonary edema. That's why in the clinical scenario, you can see that the woman is breathless and that she has lung crackles. This is suggestive of pulmonary edema, and it gets worse over time. In cardiogenic shock, the cardiac output, like I said earlier, is decreased. The systemic vascular resistance is increased. The pulmonary capillary wedge pressure, which is a measure of the pressure in the left atrium, is increased. Like I said earlier, the heart is unable to pump out blood to the rest of the body. So the pulmonary capillary wedge pressure is increased. Pressure backs up in the left atrium. Then the central venous pressure is increased because blood backs up in the venous system, like blood is pulled in the venous system because the heart cannot pump it to the rest of the body. Then the mixed venous oxygen saturation is decreased. So the mixed venous oxygen saturation is like the oxygen that is left in the venous blood when it returns to the heart. It is decreased because the organs are poorly perfused. So the little blood that gets to the organs, the organs and the tissues, the cells will try to take out as much oxygen as they can. This will now decrease the oxygen in the in the blood. So by the time it returns to the heart, the mixed venous oxygen is decreased. Let's differentiate cardiogenic shock from other forms of shock. Hypovolemic shock is caused by a blood loss or fluid loss. The cardiac output is decreased. The systemic vascular resistance is increased because when there is fluid loss, there is less blood volume. So the body, the blood vessel will try to vasoconstrict. So this vasoconstriction increases systemic vascular resistance. Then the pulmonary capillary wedge pressure will be decreased and the skin will also be cold. In early septic shock, there is vasodilation. And when there is vasodilation, the heart tries to pump faster to meet up with the metabolic demand of the body, which will increase the cardiac output. The systemic vascular resistance will be decreased because there is vasodilatation. The pulmonary capillary wedge pressure will be decreased and the skin will be warm in early septic shock. But in late septic shock, the heart, after some time, the heart can start failing because of too much toxins in the body. It will become overwhelmed by the infection. This can now make the heart to slow down and the skin will become cold. Obstructive shock can be caused by a cardiac tamponade. It can be caused by pulmonary embolism. The cardiac output is decreased. The systemic vascular resistance is increased. The pulmonary capillary wedge pressure can either be increased or decreased. In cardiac tamponade, it is increased because blood is in the pericardial space and it compresses the chambers, the heart chambers, raising the pressure in the heart chambers. And the pulmonary capillary wedge pressure reflects the pressure in the left atrium. So the pulmonary capillary wedge pressure is increased in cardiac tamponade. But in pulmonary embolism, the pulmonary capillary wedge pressure is decreased, or it can be normal, because in pulmonary embolism, there is obstruction of blood flow in the pulmonary artery. So the left atrium is not even getting enough blood because of that obstruction. Because you know that the blood flows from the pulmonary artery before it gets to the left atrium. So when there is an embolus, a blood clot there, it blocks blood flow to the left atrium. So the pressure in the left atrium can be decreased or it can be normal. And then for the skin will be cold because enough blood is not even getting to the skin. So the organs are poorly perfused. Neurogenic shock can be caused by a spinal cord injury and it leads to loss of sympathetic tone. And you know sympathetic tone causes vasoconstriction. So when there is loss of this sympathetic tone, there is decrease in cardiac output. Because if you think about it, it's the sympathetic system that increases the heart rate. So when there's loss of sympathetic tone, the cardiac output will be decreased, systemic vascular resistance will be decreased, pulmonary capillary wedge pressure will be decreased, but then the skin will be warm. The skin will be warm just like in septic shock, because if there is loss of sympathetic tone, that means there will be vasodilatation because the parasympathetic system will take over. So when there is vasodilatation, there is blood flow to the there is more blood flow to the skin. This will make the skin to be warm. When you see recent myocardial infarction, hypotension, pulmonary edema, raised jugular venous pressure, you should immediately think of cardiogenic shock. I hope this video was helpful. I'll see you all in my next tutorial.